Okay, here's what we got to know about Depakote or valproic acid. So this is an anticonvulsant slash mood stabilizer that we need to be aware of. So it's approved for bipolar 1 disorder. So that's the main thing that it treats. So acute mania and mixed episodes. But it's also used for epilepsy and to help with migraines. But primarily in psych, this is what we'll be using it for. So I encountered this medication a lot when I was doing my inpatient psychiatry rotations as a psych resident. So very, very common that we use for people who come in for bipolar manic episodes. So, and also in the prison system, we use it for aggression and agitation. So it's frequently used there too. So it's used for bipolar maintenance, it's used for impulsivity, it's used for BPD, and used for schizoaffective disorder too. So, in terms of mechanism of action, so it's got a couple different mechanisms, right? So, one is that it increases GABA levels. So, basically, it blocks the breakdown of GABA, so that increases the inhibitory neurotransmission. GABA is calming, so that works. It also blocks voltage gated sodium channels, right? So, by stabilizing neuronal membranes, basically, this will limit action potentials and so thus limiting the amount of neuronal firing that's going on, right? So that's where the seizure control benefit and some of the mood stabilization benefit comes from. Modulates some calcium channels, and similar to lithium, so downregulates protein kinase C and some other intracellular signaling pathways, and then this dampens down some of the excitatory pathways and enhancing the inhibitory pathways. So overall, like the mechanism is not as clear cut as it is for, say, SSRI, but it's like multifaceted, it's complex, and that's what leads to the mood stabilization effects. Yeah, so for example, see this shows increases the concentration of inhibitory GABA neurotransmitter, so it blocks its catabolism. So just important to recognize that. And yeah, pretty much it's got a lot of complex biochemistry that's going on, right? Not it's stuff that we really don't need to understand for clinical practice. Uh, but what we do need to understand is how we use this medication. So normally you'd start this about 200, 250 to 500 milligrams twice a day, and then you titrate it to 250, 500 milligrams every few days. Its target dose range is about 1,000 to 2,000 in divided doses, right? So it's a weight-based dosing as well that you do. Ooh, I gotta include the weight-based dosing. See, what ends up happening is that I will start writing the lecture, and then once I'm speaking it, that's when like I'll realize, oh yeah, I forgot this thing. Yeah, Risperdal. I already did the Risperdal, so that's good. I've already done Electron Risperdal already, so we're doing the mood stabilizers like Depakote. Rip. Hey, what's up? All right, all right. Would you rather teleport or time travel? Teleport. Time travel can get real wonky with time physics. If you're going by weight, generally you'd go to about 10 to 15 milligrams per kg per day. But You don't really want to go as much, by the way. That's just a guideline. You use it more for adolescents, but really it's the serum levels that you target, right? So you target the trough levels. So the mania is about 80 to 125, and then maintenance is about 50 to 100 that you titrate to. So you can use the weight-based dosing as a guideline, but ultimately it's like the level that you go by, as well as how stable the patient gets. And so you check the levels 3 to 5 days after starting or adjusting the dose. So a little bit quicker than lithium, right? So dosage form. So thankfully it's very cheap, but it comes in a delayed release and an extended release version. So 125, 250, 500, and then 250 and 500 for the ER. Thoughts on Vraylar? It's good. I like Vraylar. It's good for depression. Yeah, so the DR is dosed twice a day, and then ER is dosed once a day. And generally, what you'll do is you start with the DR, especially if you're doing acute mania. It's faster to titrate, and then once the patient's stable, you can switch them over to the extended release. Just remember that when you switch to ER, when switching to ER, may need to increase dose by 10 to 20%. And this is to maintain therapeutic levels. Because then with ER, you've spread it out so that there might be some points during the day where it's not therapeutic. So Depakote, the ER, the DR also comes in a solution, so that's nice. Comes in capsules as well, which is helpful because you can open and split them. There's an IV formulation that's available as well too. So thankfully, it's pretty cheap. The solutions used common. Of note, people say that these pills are very big. They say they are horse pills. So definitely do be aware that swallowing these is a struggle for many people. So just like its counterpart, lithium, Depakote tends to have a bunch of side effects too. So sedation is common, tremor is common, weight gain is common, hair thinning is common. So hair thinning tends to be a little bit more unique with Depakote, but all of these other ones definitely occur. Like I remember I had one patient when I was doing my outpatient years. So she was on Depakote. Was maintaining it for bipolar disorder, and so she had lost a whole bunch of hair. But she was like, I can't come off Depakote. It made me stable. Like she was having manic episodes before. So I think we started selenium shampoo, and I feel like I prescribed her minoxidil. Just to try to target the hair loss because she's like, yeah, I'm not adjusting the Depakote. Like it's that good. Neuro-wise, right? So tremor, dizziness, ataxia. So of note that too, hepatic. So this is the key difference. Depakote's hepatically metabolized, so you can cause an elevation in LFTs, so hepatotoxicity. There's hematologic risk of thrombocytopenia, platelet dysfunction. Endocrine risk is more in the ovary, so PCOS risk, hyperandrogenism, right? So hormonal stuff, weight gain, insulin resistance. It's very teratogenic, so neural tube defects are very, very well known. So you don't want to be using this in pregnancy at all, right? Unless it's like very, very, very needed, and like you use it after the second trimester onward. Uh, but yeah, just remember that this is hepatic, whereas lithium is renal. So, contraindications are liver disease, hepatic dysfunction, any kind of urea cycle disorder, right? Like what has to do with nitrogen usage. This can increase the elevation in LFTs too. So be wary of that. So pregnancy, right? So it's category X for migraine, D for bipolar. So definitely not recommended. Um, and the thrombocytopenia and bleeding, because this can have a risk of thrombocytopenia and platelet issues. So monitoring wise, right, this also is monitored. So you do the same 12-hour trough. So a therapeutic range is 50 to 125. LFTs you have at baseline, then every 6 to 12 months. CBC you do, thrombocytopenia, weight, BMI, metabolic labs. The ammonia level, you want to check that for sure too, because that can increase with Depakote. So that's why urea disorder cycles are a contraindication, because they you can't process ammonia with them properly. Definitely pregnancy test. So this is not the ideal medication for a young, like 20s female who has yet to get pregnant. So definitely be wary of this, right? And also be wary of any kind of mood symptoms that can develop. So, otherwise, pharmacokinetic wise, right? So several days for mood stabilization, so relatively quickly, and quicker for agitation too, which is helpful because it can be used for like not acute agitation, like right away, but if you need to stabilize an agitated patient relatively quickly, like within like a few days, then Depakote is a good choice to do that. Half-life, right, about 9 to 16 hours, so a little bit longer in the ER form. So that's what the DR, delayed release, is about. BID dosing, ERs once a day. So metabolism, hepatic, right? So really good to know that. So it does get, like, some of the metabolites get excreted renally, but like that's not a big processor for it. It's definitely the hepatic processing. That's what you got to be aware of too. And also, so nonlinear kinetics at higher doses, meaning that as you get to higher doses, it's not like the dose increases gradually, it's more exponential. So definitely worth noting that. Overall, though, it's more effective than lithium in for rapid cycling, mixed states, and maybe some dysphoric mania. So notice the difference. Whereas like lithium is better for that euphoric classic type of mania, this is better for that rapid cycling. If there's mixed states, a lot of the anger or a lot of the depressed type of states for it too. If there's agitated or irritable, then you can use Depakote for that kind of mania as well too. Or if they're impulsive, doing a lot of that kind of stuff. So the ER formulation can reduce some of those peak side effects, right? So that's helpful. Usually you'd start with the DR, then go to the switch over to the ER if you're treating something acute. You want to avoid it in pregnancy, of course, due to the high risk of birth defects. That's key. Off-label for aggression, mood stability, uh, folic acid supplementation. So that's a key point as well too. So basically, this Depakote will use up folic acid, and that's what causes the neural tube defects. So at least if you supplement with folic acid, that can help with, if there's, let's say, a reproductive age female gets pregnant, that can reduce the risk of any kind of neural tube defect. Uh, in terms of med interaction, so it inhibits lamotrigine metabolism. So basically, it prevents lamotrigine from breaking down. So if you're using the combo for mood stabilization, recognize that it does that. So you probably need a lower lamotrigine dose than you think. And you have to monitor drug monitoring. Like that's so key for this medication as well. But overall, think of it like counterpart to lithium, both very efficacious in bipolar, but both have very significant side effects as well. So it takes some skill to be able to utilize this, but this can really make a difference for the right patient. Yeah, no worries, Sam. We all have our strengths and weaknesses. We all have things we're good at and things we're not so good at. I know, what I such a poser. What is the maintenance dose ADHD Wellbutrin? Like 150, 300. Okay, so that was Depakote. Hey, Levita. Okay, and now we are doing Tegretol. Thoughts on Tegretol? That's so funny. Okay, here's what we gotta know about Tegretol or Carbamazepine. So this is another one. You don't see this as commonly, but it's definitely used as a mood stabilizer. It's also an anticonvulsant. So for us, we're gonna be mainly using this for bipolar disorder or for aggression and impulsivity. So those are the top two things that we will use this medication for. Uh, so carbamazepine, basically, it's a anti-epileptic that they found had mood benefits, right? So it helps stabilize the mood, helps reduce neuronal hyperexcitability as well too. So it blocks voltage-gated sodium channels. So basically, you block the sodium channels, you reduce the action potential, so you have less neuronal firing. Inhibits glutamate release as well too. So by inhibiting the glutamate release, then you reduce some of that excitatory transmission. It has some effects on dopamine, serotonin, right? There's a concept of kindling. So, as mood episodes get worse over time in bipolar, like there's a tendency that, especially if it's untreated, then the mood episodes can get worse and worse. And so this is thought to help reduce that worsening. Uh, and there's some anti-manic effects too that they think are related to limbic system excitability. So basically calming down the limbic fight or flight type of system. So overall, voltage-gated sodium channels, reducing glutamate. These two are the common things for it. In terms of its dosing guidelines, so you start at about 200 milligrams twice a day, or 400 milligrams of the immediate release, because there's two different formulations. And generally, you would go to about 800 to 1200 milligrams per day, max 1600, and you divide those doses, right? Especially with the immediate release, but even with the extended release one, especially if you're on a big dose, you want to decrease it. The serum target level is about 4 to 12, so same trough level, right? And the levels that can actually decrease over time. So this is key. Basically, it's got a thing called autoinduction. And so the way that the autoinduction works, right? So it's broken down by CA4, but it also induces CA4. So it basically induces its own enzyme that breaks itself down. So that's the thing to be aware of with carbamazepine. So the dosing can be a little bit wonky with it, or like the efficacy and the serum level, because of this autoinduction. It comes in 100 milligram, 200 milligrams forms. Luckily, it's pretty cheap. It's been around for a long time, right? As a anti-epileptic, it's definitely got its risk of side effects of dizziness, ataxia, sedation, diplopia, nausea, leukopenia, right? So all of these are very common, especially the dizziness, very common with this med. There's a risk of Stevens-Johnson syndrome as well too. So of note, worth noting that. The risk of hyponatremia, so that's an important risk. especially with this medication. To note, tremor can happen, cognitive slowing, etc. So some important stuff can happen with Tegretol. So any contraindication. Oh, and then the agranulocytosis and aplastic anemia. So that's really important to recognize too. So, in terms of contraindications, right? So the bone marrow suppression, very important to, that's a contraindication, right? Because of the aplastic anemia or agranulocytosis, right? Infection risk can be high. Uh, there can be, and if there's any kind of hematologic reaction, especially to something like carbamazepine, you got to be careful, or like to another medication. Um, HLE-B2 allele status, that can be a trigger, especially for Steven-Johnson syndrome. Any recent MAOI use, hypersensitivity to any of these compounds. Cymbalta, I like Cymbalta. It's good for pain. Is it true benzos improve social anxiety in 100%? Probably not 100%, but it can improve social anxiety for people. And then of noting, so you don't want to use this with nifazodone or lorazepam. So basically, especially with the lorazepam, that's the one you'll use more commonly. It metabolizes the lorazepam through the CYP3A4. So you got to know this. Serum level wise, right? So 4 to 12 micrograms. You check after 4 or 5 days, and you periodically check. You want to be doing a CBC very regularly, right? Because of the agranulocytosis risk. LFTs you want to be doing. Sodium, you want to be monitoring for hyponatremia, pregnancy test, any kind of genetic screening, especially in like that high risk group, right? So the Asian groups that we had mentioned before, right? So that can be a risk. Yeah, Asian ancestry. Um, yeah, and then drug interactions as well, too, at the CYP stuff. So, in terms of pharmacokinetics, so it takes about 7 to 10 days for start noticing mood benefits. So a little bit more than Depakote and lithium, too. Quicker for agitation, but not as quick as those. So 25 to 66 hours, 65 hours, so pretty long initial half life. But then as it starts inducing itself, it drops to 12 to 17. Which is a significant drop from here to here. Yeah, as we mentioned, the CYP has an autoinduction, and the serum levels can decline, as the autoinduction becomes more and more relevant. So you may need like this dose or like this half-life, or slightly longer. So overall, think of carbamazepine for those people who have dysphoric mania. They've got irritable, mixed, so a lot of those negative mood states, rapid cyclers. Uh, you just got to be careful of CNS effects. You have to educate people on rashes. Any kind of infections or mood destabilization. Um, be mindful of the CYP interactions, right? But luckily, there's no big hepatic or renal issues, so that makes it nice too. And then you want to be cautious if the patient's got multiple stuff going on because of the interactions. So overall, this is like not a first choice, first line mood stabilizer, but it can be used. Like I've used it maybe once or twice, but it's not generally my go-to. Like there's other options like lithium or valproate, or antipsychotic options that are there. It makes me less pressed to go towards Tegretol, which tends to be a less strong mood stabilizer, unless I have a good reason to. Like for example, the other two are contraindicated. Oof. Ooh, I'm kind of tired. I should have some coffee. Or a little bit of dark chocolate. Maybe some dark chocolate would be nice. So we just did carbamazepine. Take on fluoxetine. I like it. It's one of my favorites. Bro, you gotta do something other than work. Yep, work and go in the gym. The important things in life. Why am I always dizzy? It's not an ear issue. Maybe it's a drinking issue. Okay, here's what we got to know about Oxcarbazepine or Trileptal. So this is also an anticonvulsant and a mood stabilizer. So it's used FDA or FDA approvals for partial seizures, but off-label we use it for bipolar disorder. We use it for mood lability, impulsivity, and for aggression as well. I tend to think of it overall as like a more better tolerated carbamazepine, but also a little bit weaker. So it's got similar effects of blocking the voltage gating sodium channels, reducing glutamate, excitability, reducing the neuronal firing, modulating calcium and potassium channels, right? But then the nice thing is that there's no autoinduction. So it gets metabolized pretty quickly to its metabolite, and because of that, it doesn't have the autoinduction. So that's very, very key. So for dosing, you'd either start at 300 milligrams twice a day IR or 600 for the XR. And you titrate up every 3 to 600 milligrams, right? Go to about 900 to 2400 milligrams. There's no serum level target that we use, so because it's just not really monitored that much. But just recognize that it is renally excreted, so you have to do some renal adjustments. So as we were talking about, so the dosage form IR and XR. IR is available, super cheap. The XR is a branded one, so it's a lot more expensive. I take it for trigeminal neuralgia. I need to salt my food. Is that oxcarbazepine or is that carbamazepine? So unique side effects to be aware of, right? So the dizziness, somnolence, fatigue, nausea, ataxia are very common with Trileptal. Neurologic wise can cause headache, vision changes, diplopia, right? So that's more worth knowing. Rash, know that. There's a lower risk than carbamazepine, but still just worth being aware of. Hyponatremia, so definitely worth knowing this. It's way more common than with carbamazepine. So that's the key one that stands out. Tends to be a minimal enzyme induction, so that's nice. So no autoinduction, right? Weight neutral, so that's nice too, because most of the others are weight gain. And there's low risk of agranulocytosis or aplastic anemia, so that's helpful as well too. But contraindications, it's main things are like if there's an allergic reaction to carbamazepine, that can cause sensitivity for this too, and a lot of people actually do have carbamazepine allergies. And then definitely be wary of people who have sodium dumping or sodium wasting conditions. In terms of monitoring, so sodium level, is you want to be able to check that pretty regularly, right? Because the hyponatremia risk. Checking your CBCs for the blood levels, right? Making sure no agranulocytosis. Checking the LFTs as well. Renal function, right? Just because it's excreted renally. Mood and behavior symptoms, right? Monitoring those. But then you don't have to do any kind of levels, so that's nice. And its effect can begin within days and full effect in 1 to 2 weeks, so not bad, honestly. Half-life about 8 to 10 hours, so dose BID, so not bad either. Metabolism, hepatic route, right, but it's not CYP, and then excreted via renal, so a little bit of both. So overall, what you should know about this. So it's used for bipolar disorder. It's not as good as lithium or valproate, but it can be used in poor tolerance. So it's better tolerated than carbamazepine, so that's nice. If you want to avoid weight gain, then that's when you can consider this one. Hyponatremia is the main side effect, so you need to be aware of this in people. If they have agitation, emotional lability, or impulsivity, it's a good choice for that, especially for the agitation. XR can reduce those fluctuations and stuff, but of course, way more expensive. Um, doesn't have the enzyme induction, so that's very helpful to know as well too. And it's frequently used in kids and adolescents with mood stability or aggression because of how better tolerated it is compared to carbamazepine. So not something that at least in outpatient practice, you'll probably be using often. You won't be using often. There's generally other superior options, but it can be like something in the back of your toolkit to have and be aware of. Best mood stabilizer, probably lithium or Depakote. They're the strongest. Starting to lower my dose off Effexor from 150 to 75. Scared to go lower. Maybe go a little bit slower from 150. Could go to 112.5 and then 75. So that way the drop is a little smoother. Yeah, cross tapering is good. That's what I usually prefer. Now we're getting to some fun stuff. Okay, here's what we got to know about Alprazolam or Xanax. So this is a benzo and generally falls under the short-acting class of benzos. So definitely important you know this. You will see this medication a lot in your career. So it's approved for GAD and panic disorder, but off-label it's used for insomnia, any kind of acute anxiety, acute agitation, used for like medication as per procedures and planes, dental appointments, that type of thing. And you can use it as an adjunct for, let's say, SSRI titration, for depression, for mania, that kind of thing. And so the way that alprazolam works, so it enhances GABA activity. So it binds to the benzo site on the GABA receptor. So that what increases chlorine channel opening. Basically, that goes downstream. It reduces the excitability of neuronal membranes, basically decreasing action potentials, making them more hyperpolarized, right? So basically just slowing things down. So that's what gives it anxiety relief, sedative benefits, muscle relaxant, and anticonvulsant effects. So, right, so basically here, if you look, right, you got the benzo binding site, the GABA receptor, benzo binds to it, and then that causes GABA release and hyperpolarizes it, so that way this membrane was less likely to do action potential activity. So that's the important thing. So primary effects in the amygdala, the fear center, hippocampus, memory area, and then the cortex, which is the frontal lobe, right, doing all the overthinking. So important to recognize that this is the same receptor as alcohol. So that's why like stacking these is a big no-no. Uh, so in terms of dosing, so this one, but 0.25 to zero point 0.5 milligrams 3 times a day, right? Like if you're doing scheduled treatment, max about 4 milligrams a day. For panic disorder, you do about 0.5 milligrams 3 times a day, and then you target 1 to 6 milligrams, right? You want to go slowly to maximize sedation. This is generally better for short-term use rather than long-term. So it's important to recognize that. And there is an XR formulation, but it's rarely used in my experience, because if you're going to use an XR, you might as well use another benzo like Klonopin or Valium. Uh, so luckily it's pretty cheap. It's available everywhere. IR comes in 0.25, 0.5, 1, and 2 milligrams. You know, the XR comes in 0.5 to 3, so it's got a variety. There's an oral dissolving one too for a little bit quicker onset. So, you know, pharmacokinetics wise, so I wanted to cover this, right? So onset is rapid, 15 to 30 minutes, peaks in about 1 to 2 hours. You know, the XR is about 4 to 10 hours. Half life is about 11 to 16, technically. However, you know, as anyone taking it can tell you, that's why it's dosed 2 to 3 times a day, is because the effect, the anxiolytic effect, lasts about 4-ish hours. So it doesn't last a long time. And so that's why it can cause higher dependence, because there's a big like risk and fall, risk rise and fall of the levels. So side effects are unique, right? Sedation, fatigue, dizziness, cognitive slowing, even some amnesia after you take this, dependence, withdrawal risk. So definite problems with this. Like I've had many patients come to me and they want to get off Xanax, or they just get stuck on this Xanax and then they need to get off. And I think the problem comes into is that people aren't aware that either that this is a hard med to come off of, or that it starts off pretty innocently and then like the use escalates pretty quickly. It's that rise and fall, and oftentimes a lot of PCPs prescribe this med without knowing the nuance behind it, or how hooked people can get on Xanax. It can cause what's called paradoxical disinhibition in some people, meaning that just like alcohol can disinhibit, this can also disinhibit and make people do stuff that they normally wouldn't do. There is a risk of respiratory depression. It's a depressant, right? So along with opioids, or in the elderly, there's definitely risk of respiratory suppression. For example, like Ativan and Zyprexa, that can cause a respiratory depression risk. Rebound anxiety is very common with this too, especially if the medication is discontinued. So it's worth knowing all that. Glaucoma is a contraindication with this med, right? Just the acute narrow angle one. Uh, Getting your AS and then BS in psychology will make masters easier. You have to get your associates before your masters anyway, right? Like that's assumed. So this is mainly due to yeah, pupillary dilation. So that's the main reason for it. Um, if you don't want to use it with 3A4 inhibitors, that can increase the dose of this medication. Pregnancy, so all the benzos are category D, right? There's some teratogen risks with this, right? Literally think of it like alcohol in a pill form. Substance use disorder, right, is a big risk or a contraindication for this as well, too. Yeah, so as I mentioned, so hepatic YCYP3A4, so anything that inhibits that will spike up your concentration significantly. Right, and also worth knowing that it's very rapid. So big reason that it's abused is because it hits rapidly. So as we'll talk about, like some of the other benzos, they don't hit as quickly, so there's less of a dependence risk associated with that. But overall, some main things to know, right? So it's used for rapid control, for panic, severe anxiety, but really just be careful that it doesn't delve into long-term use. Uh, Usually you would use an SSRI or SNRI for maintenance, then you can use the Xanax as a bridge. Tapering, you definitely need to taper it. Withdrawal is definite thing, can cause seizures, right? So just like alcohol withdrawal can, so you just have to be careful. Yeah, definitely avoid with anything else that's CNS depressants, right? Use in the elderly with caution, right? Fall risk, impairment, yeah. And there's thought that it can worsen depression or irritability too over time with people. So overall, like this med has its use, but you have to be a good steward of this as a provider. It's definitely not a med to prescribe lightly. I'm an undergraduate down the line, chemistry major, planning to do a PhD in pharm. Nice, nice. Antipsychotics a good idea for someone who has slight GAD. No, they're not really used for that. The risks seem greater than the benefits there. Okay, here's what we got to know about lorazepam Ativan. So, lorazepam or Ativan, so this is another benzo, so it's approved for anxiety disorders, some pre-op sedation. Off-label, it's used frequently for agitation, used for withdrawal, used for catatonia, used for insomnia, uh, and a little bit as an antiemetic agent, but like these four are more the primary uses. So mechanism of action, so it enhances GABA activity, right? So it bends to the GABA A receptor and the benzodiazepine site there. So basically that's what causes hyperpolarization of neurons, decreases excitability, decreases the uh, production of an action potential, which, by increasing the chlorine, making it more negative. So that's what gives it more anxiety, sedative, hypnotic, muscle relaxant, anticonvulsant effects, all of those things, right? So pretty much just hits the GABA receptor and, yeah, promotes GABA release. So, and that's because it occurs in the limbic system and the thalamus, right? So thalamus associated a lot with muscle movements and signal transduction across different areas, limbic system, and then hypothalamus as well too. So its dosing is about 0.5 to 2 milligrams. So Ativan is approximately 2 times, or it's half as potent as Xanax. So the dosage is double. So Xanax you start at 0.25. This you start at 0.5, and so dosed about twice a day to 3 times a day. right? Insomnia, 1 to 2 milligrams. Agitation, usually 1 to 2 milligrams, IM or IV. Catatonia, 1 to 2 milligrams, and that can be repeated over time, right? The catatonia has its own protocol with Ativan, and then it's also used for alcohol withdrawal as well. Too usually you'd use a SIWA protocol to help guide your Ativan tapering or your alcohol withdrawal stuff. So Ativan definitely a very common medication that's used. So note that it's very cheap. Comes in a 0.5, 1 milligram, 2 milligram. It can be split, so that's helpful. Also comes in an oral solution. I have one patient who has like esophagus difficulties, so she takes the oral, and then there's an injection form as well too. So there's 2 milligrams, 4 milligrams IV, and IM, right? So injection I definitely will use a lot if you're in any kind of agitated setting, like it's one of the go-tos. So unique side effects: sedation, dizziness, fatigue, weakness, confusion, anterograde amnesia, right? So forgetting after the fact. So agitation that can happen. It's kind of like disinhibition, respiratory depression. Also note that combining Ativan and Zyprexa, there's a theoretical risk of respiratory depression. So you don't just want to do it in a clinical setting. You don't want to do that. Even though the data is weak on it, it's more like if you get sued, then it's easy to say that, yeah, the recommendation is not to do it. Tolerance, dependence, and withdrawal with prolonged use, right? So just like Xanax and withdrawal symptoms too. So it's of worth noting pharmacologically and pharmacokinetically at least. So the peak effect is about 1 to 2 hours. Onset is about 20 to 60 minutes. So at onset is a little bit slower than Xanax. So the dependence risk is slightly less. Like it doesn't hit as quickly. Uh, so it's worth noting that. IV though hits pretty quickly, 15 to 30 minutes. IM is quicker as well too. Half-life about 10 to 20 hours, but of course the peak effect or the onset tends to be around like 6 to 8ish hours. So usually if you're dosing during the day, you dose it BID as well too. So it gets conjugated hepatically, but it's not CYP dependent, so that's different compared to Xanax. So it's worth noting that. So this is what has to do with the lipophilicity, right? So that's why it hits a little bit slower than Valium or Alprazolam. So it's worth knowing that too. So that makes it slightly less addictive, but it definitely still has that addiction. And so these are some of the contraindications, some of the things to monitor for over here. And overall, so if there's any kind of liver disease, you would use this, right? It doesn't have the CYP metabolism, unlike Xanax. Catatonia, like this is what's used because, it's been the most studied. You get quick response from it for a lot of catatonia. I use it IV for epilepsy or status epilepticus. For agitation, right? The effect tends to last a little bit longer. And so there's less of that addiction risk too, slightly less. So it's good for short-term anxiety or insomnia, but then chronic use can be a problem. Be mindful in the elderly because of falls, delirium, cognitive impairment, that kind of thing. And then avoid with opioids, other CNS depressants, or olanzapine. Olanzapine. And yeah, I mean, this is a med you'll see very frequently, so you definitely should be knowing the details on this one. Yeah, olanzapine, and it's IM. Yeah, exactly. So it's for agitation. Huh. I also meant to say for severe anxiety, panic. Okay, and then now we have to do, let's do Klonopin. Yeah. Yeah, it's usually the IV, like, I mean, for agitation. PO, it's whatever. Okay, here's what we got to know about clonazepam or Klonopin. So this is a benzo and it's a longer acting benzo. So that's the main thing to really know about it. So pretty much has similar indications. So panic disorder, some seizure disorders as well too. But off-label is used for GAD, social anxiety, insomnia, for catatonia even, mania, some kind of agitation, psychosis, TD we use it for. You can use it for alcohol withdrawal, for restless legs, for REM sleep behavior disorder. I'll even add in Tourette's or akathisia. So all of those things. So it has a lot of uses. So same activity as all the other benzos. So pretty much the benzo site hits the GABA A receptor. So all the same kind of activity. Klonopin, the potency is similar to Xanax, meaning that and half of or double of Ativan's potency, so less half the dose. So that's why you start at 0.25 instead of zero point 0.5. Generally, you would dose this about twice a day. You can do once a day as well too, but generally about twice a day. For panic disorder, go up to about 1 milligram, give or take. And then max dose is usually about 4 milligrams per day. For seizures, it's used as well too, but you're not going to be using it for seizures. But then for the other stuff, right, like the anxiety, insomnia, social anxiety, that's where you can adjust the dosing. Zero point 0.5 to 2 milligrams is generally as standard, right? And you want to taper it gradually if used longer than 2 to 4 weeks, because it can cause some withdrawal, but at least it's a little bit easier to come off this med than Xanax, for example. So luckily, it's pretty cheap. Comes in 0.5, 1 milligram, 2 milligrams. There's an ODT form as well. So this has this nice because it's got the smaller dose of 0.125 and the 0.25. So you're going to get a little bit tinier dosage here. So it can help with tapering. And the ODT has faster absorption. So that can help with, let's say, if you need the acute reason for it. And the tablets can be split as well, too. So pretty much all the same side effects as all the other benzos. Nothing that's unique with this one. In terms of side effects, same thing with the contraindications as well too. But just note that so there's no IM form for Klonopin, so it's not used as a agitation med. So yeah, same things that you want to monitor, just like all the other benzos. But kinetic wise, right? So onset's about 20 to 60 minutes. So it's similar to Ativan, so it's not as quick. It's not as quick as Xanax or Valium. So it's more like Ativan, but the peak effect lasts 1 to 2 hours, 1 to 4 hours, and the half-life is 18 to 50 hours. So that's the key thing with this, is that it lasts a while. It's not a quick lasting med. So that's why this is used when you really need something that's more like a long term. If you have someone on a benzo as a daily use, then this is likely your go-to choice, especially if they need the daytime coverage. So it is broken down via CYP3A4. So liver, right? So you just want to be mindful of liver effects. So overall, main things to recognize from this Klonopin is long acting, right? So you need it for stuff that needs a sustained effect, right? So you can use it for panic disorder, especially if you want to avoid panic attacks over a certain duration. Seizure disorders, insomnia, especially like a maintenance insomnia. Social anxiety, you can use it for, right? If the social event lasts a while. So there's a less risk of rebound anxiety, a little bit less risk of dependence. There still is a risk of dependence, but comparatively to Xanax and Valium, it's a little bit less. You definitely still need to taper this slowly because of withdrawal. You want to avoid in the elderly because of sedation risk, and just be mindful of certain opiates that people are using already due to risk of respiratory depression. But sometimes if you have to, you have to, right? Like I have a cancer patient I take care of. She's on chronic benzos, so she has a lot of anxiety, but she's on opiates as well too. They just recently added that, so I'm not adjusting the benzo, but I don't think I want to take it away either because she has pretty severe anxiety. So definitely worth knowing this med too, and then knowing the differences between this and all the other benzos will be helpful because that will let you to dictate your choice. Why am I bored on Latuda? It's probably a you thing. But it can cause some emotional blunting as well. I was on clonazepam for years for multiple symptoms. Been on lorazepam. Lorazepam does help, it just doesn't last as long. So you can feel the come down of it. Unless it's a short social event you go to. Okay, here's what we got to know about diazepam or Valium. So this is a long-acting benzo. So pretty much it does the same thing. It enhances GABA at the GABA receptor, right? So it has the the hyperpolarization of neurons. A similar concept, uh, similar uses as well too. So anxiety, panic attacks, alcohol withdrawal, muscle spasms. So worth noting that. Uh, This one I'm going to redo. I have social anxiety, panic disorder. Clonazepam does help longer. I'm also on Effexor 150 XR a day. Nice, yeah. Doing therapy for the past 2 months. Would clonazepam be a better choice for Effexor? No, not really. You'd want to optimize your Effexor first and then use clonazepam as needed. Could I take it like an hour before an event? Yeah, that's the best time to take it. Like 30 minutes to an hour. But you probably want to test out the dose before to make sure you don't get sedated. Like you probably don't want your first time to be at that event. I'm on lorazepam, zero point 0.5 mgs a day. Is that a low dose? Yeah, that's pretty standard. That's a starting dose. In your field of work, do you have therapy? I mean, I tried it for a year. I didn't really feel like I needed it personally, but yeah. But it carried over to daytime. Yeah. 1 milligram 4x a day. That's a lot. How do I taper off Latuda 60 if I've been on for 5 years? It's not the hardest one to taper off of. It's not terrible. Uh so yeah, basically you just come off slowly. You just go to 40, then 20, and then should be good to go after that. Okay, here's what we got to know about diazepam or Valium. So this is FDA approved for anxiety disorders, acute alcohol withdrawal symptoms, muscle spasms, helping out with seizures, and some pre-op sedation as well. So those are the FDA approvals. But off-label is used for insomnia, catatonia, panic disorder, REM sleep behavior, agitation, night terrors, spasticity, vertigo, mania. So a lot of and tapering as well. So it's got a lot of off-label uses, and it has some unique stuff with it. So basically, mechanism action pretty similar. So GABA A reactivity, right? So increasing the chloride channel opening, hyperpolarizing their neurons, decreasing action potentials. Pretty much the same effects as all of the other uh, benzos. But in terms of dosing, right? So it's got different air things that it's used for. So for anxiety, it's used so about 2 to 10 milligrams twice a day to 4 times a day. Alcohol withdrawal, 3 to 4 times. Muscle spasms, 2 to 10. Right. So all the dosage varies, but recognize that it's a more of a low potency, right? That's why these dosage numbers are higher. So zero point 0.5 of Xanax is equivalent to 10 milligrams of Valium. So just recognize that. Luckily, it's pretty cheap. It comes in an oral. It comes in an injectable as well, too. Pretty much the exact same side effects that all the other or the other benzos have. Pretty much the same contraindications as well, too. Myasthenia gravis is added in there, but really it's all the same contraindications. Um, as all the other benzos, So the main thing that we should know for this is the onset. So the onset is quick. It's very rapid. So it hits quickly. So it's got rapid CNS penetration and it lasts a long time. So this is think of it like combining Xanax and Klonopin together. You get the long duration of Klonopin, but you have the quick actingness of Xanax. So this actually makes it the most it has the most addictive potential along with Xanax. So long half life as well, and the peak is very quick too. So that's worth noting as well too. So that's why with that long half life, that's why it makes it ideal for withdrawal management and for tapering. So for example, let's say you have a patient on Xanax or Ativan like a couple times a day, you can actually do a direct switch over to Valium at an equivalent dose and then taper off of that. And that's a lot easier uh, to come off of because of the high dosage or the high duration length. So that's why it's used for seizures, it's used for alcohol detox, it's used for muscle spasms. Uh, there's a risk of accumulation though because it lasts so long, right? And because you get such a quick effect, then people can take it relatively. They can stack it, and that's where you can get a huge duration stack uh, for that. So definitely mindful of that. You want to avoid it long term for anxiety. You definitely still want to come off it slowly, right, for the withdrawal risk. And overall, just be cautious with opioids due to respiratory depression. But those are the main things to really know about diazepam, and like that's the unique stuff compared to everything else. The tapering is one of the most unique things. Last, low potency, long acting, very quick acting. Okay, here's what we got to know about temazepam or Restoril. So this is an intermediate acting benzo. So pretty much it's got the same effect as all the other benzos. Uh, but the main reason we use it is for insomnia. So it helps for both sleep onset and sleep maintenance insomnia. That's the main reason for this med. Just gonna redo that one. What's your plans for later? I'm gonna be probably going to be uploading some of this stuff, these new lectures I record, onto my coaching program. And then tonight, we're running a process group in our coaching program, meaning that we're just going to be sharing, some of the negatives of working in the mental health field, some things that are overwhelming us, annoying us, insecurities we have. Struggles, that kind of thing, in a trusted group environment, right? So we're going to be doing that in our group. It's called the process group. We did it a lot in med school, where like it was helpful for burnout, discussing problems and issues that we had, just basically kind of like venting it out. Then getting the support of and empathy from other colleagues who like obviously understand the same thing. So that will be happening for our coaching program. That will not be live streamed, so that's you're not going to see that. But yeah, that's the main plan I have. Otherwise, nothing really else. That's it. All I heard is work. Where yeah, of course. Yeah, I already went to the gym today. I already ate today. So that's the goal. See, my life philosophy is that work is a video, or life is a video game. So uh, this is fun for me. I'm leveling up. Like we are leveling up constantly. So that's why it's fun. Like why spend your time getting achievements and trophies in a game when you can when you can do that in real life? Yes, so always remember that you control your thoughts and you control the perspective in which you see things. So if you can choose that, then why not choose a perspective that benefits you? Like I remember hearing this one YouTuber say it. He was like, anytime if you tell yourself if you can do something or you can't, like you're right. And so why would you argue against yourself? Like why would you bet against yourself, right? So if you're like, hey, oh, I can't go to the gym because of I'm busy or whatever, like you're literally just arguing against yourself. Why not argue for yourself and say, oh yeah, I can go to the gym because of this, because I do have time to go on evenings, for example, rather than I can't go because I work all day. So always argue for yourself and alter your thoughts to help you and not to hurt you. Okay, so here's what we have to know about temazepam or Restoril. So this is FDA approved for mainly sleep and insomnia, but off-label we use it for sleep maintenance, REM sleep behavior disorder, catatonia, and night terrors, sometimes sedation, but mainly it's sleep related. Uh, so it enhances GABA A activity, so it pretty much does similar activity to all the other benzos. Do 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 do. Do, 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 do. And so the main reason it's used in sleep is because that's how it was marketed, right? So you see that these FDA approvals, like that's when the drug companies will market something. So they marketed it for sleep. And so that's where it gets mainly used. And so the reason for that, pharmacologically, so its onset is a little bit slower. So it doesn't really kick in immediately, so it's less useful from the benzo perspective of anxiety relief, and it lasts a decent amount of time, like 8 to 20 hours, so it's pretty good. Like at least that's a half-life, so at least it lasting is about 5 to 6, so it can be helpful for maintenance as well, so as well as the insomnia. So that's where that really comes in from. So it's dosed, and it's less potent too, so it's dosed about 7.5 to 30 milligrams at bedtime, and generally you start about 7.5, you start at 15, and then you go from there. So 7.5, 15, 22 and a half, and 30 is the forms. It's available, it's cheap. Generally I found that a lot of my old patients when I was in residency, they were on Restoril. uh, so it was definitely a favorite of some like older docs. A lot of those patients got transferred us from PCP. Pretty much the same side effects as all of the other benzos. Just be mindful of the complex sleep behaviors, right? Sleepwalking, sleep driving, eating while sleeping, right? Just because it tends to be diagnosed primarily at nighttime. So just be cognizant of that, right? The withdrawal is definitely a thing. The addiction is definitely a thing. Like all those patients I had on Restor, like they did not want to come off of that medication at all. And so like it wasn't something that I was gonna fight them on it. And they were all elderly too. But they were like they said they absolutely needed it to sleep. I definitely want to avoid this in pregnancy if we can. Also for severe hepatic impairment, we want to avoid it as well. Monitoring wise, pretty much the same monitoring stuff as all the other ones, the sleep disorders, right? Be mindful of that. The onset we talked about, the peak effect, the half-life, hepatic metabolism. So it's not by CYP, but a different one called conjugation. But point being that still hepatically metabolized and then renally broken down. And there's no active metabolites. It's just this thing gets broken down. So that way it's a lot bit cleaner, it tends to be better tolerated. So contrast this to venlafaxine, which gets broken down to desvenlafaxine, and the venlafaxine to desvenlafaxine breakdown has a lot of metabolism problems. So overall, it's the immediate half-life, right? That gives it the sleep onset, sleep maintenance help. Um, you get less rebound insomnia because because it's a little bit more longer acting. So a little bit safer in hepatic impairment. So this, along with Ativan, are your top two for that. So you can definitely be mindful of residual morning sedation. It's less likely with this one, but it still can happen. Avoid obviously, it's a benzo. You want to avoid it long term, and you want to be monitoring for complex sleep behaviors and like discontinuing too, if you notice that. So yeah, that's the main things to know about rest oral, like sleep. All right, time to record one more, and then I'm calling it. Okay, so here's a quick chart comparing all the different benzos. So of note, right? So if diazepam 10 milligrams is the equivalent dose, so alprazolam or Xanax equivalent is about 0.5. Its onset is intermediate, right? So intermediate. I think I'm gonna. Okay, here's what we got to know about the different benzos. So just a high level overview, right? So alprazolam, so Xanax, so zero point 0.5 is equivalent to 10 milligrams of diazepam or Valium. It tends to hit pretty quickly, so rapid onset, and but its half-life is definitely shorter. So that's why it's dosed about 3 times a day-ish, right? So that's what leads to more of that frequent dosing. You have a high risk of rebound anxiety. So that's the main things about Xanax. Then you have, let's do lorazepam next. So lorazepam is more intermediate. So this one's short half-life. Lorazepam is intermediate half-life, longer than that. So it's about half the potency, so double dose for the equivalent, so 1 to 2 milligrams. Onset of action is intermediate, so not as quick as Xanax. So a little bit slower acting, but it's preferred for hepatic impairment, and this one's used the most for agitation as well. Then you have Klonopin. So Klonopin is longer acting. So this one also is intermediate, so it kicks in a little bit slower than Xanax does, like similar to Ativan, but it's longer half-life, so you can dose it less frequently, like once or twice a day. So you just want to be more, so it's more useful for like anxiety that's spread out. Uh, then you got Valium. So think of Valium like so 10 milligrams, right, is the standard, hits rapid. So think of it like combining the Xanax onset of action plus the Klonopin half-life. So it combines the best of those, or like, no, I wouldn't say the best, but those properties. And so the rapid onset means that it gives quick relief. So it can be useful in a panic attack situation. Um, but then it accumulates, right? So that's the downside of it. That's the main problem with it. So if you stack it, then that can be a problem. But then let's say there's like a panic attack and then you want them to be covered for the rest of the day, then diazepam Valium is a good choice. But it makes it less of a good choice if the addiction is more severe due to its rapid onset. And then you have temazepam. The equivalent is about 20 milligrams. Restoril, pretty much just used for sleep. Uh, it's a little bit slower acting, so it doesn't give that immediate sedation, but the duration is about an intermediate, long lasting. So that's why it's used for sleep initiation or for sleep maintenance. And like those are the high yield facts about the different benzos. Yeah. Restoril, yeah. All right, so that we just recorded like 10 different lectures. So we've been live for 83 minutes. So I think now is a good time to call it, kind of chill out for a bit, uh, gather my mind back, and then, yeah, just going to be working on some other stuff. And then I'll probably see you tomorrow.